a board-certified internal medicine physician, and I'm called an extensivist. Essentially, I'm extending the care of what is done in the hospital, and all I do is post-acute care. So I take care of essentially anybody above the age of 40 and above, but ideally my population is, senior citizens and people above the age of 75. And I've come across a lot of people that by the time they get to me, they have a lot of questions and they don't know where to begin in terms of where do we go with some of these decisions in post-acute care. And I've just come to the decision that I need to start spreading the message beforehand so people are more armed with knowledge before they get to me. So we're going to talk about a couple things. Basically understanding the different levels of care. I mean, what is assisted living? What is skilled nursing, long-term care, that type of stuff. And then I talk a little bit about advanced directives. What does that mean? What is involved in resuscitation? Polypharmacy, too many patients taking too many medications, and how does this happen? And how can we help reduce those issues? And then starting to arm yourself with knowledge to take control of your own care. Also, understanding the role of your primary care physician and the subspecialists, and avoiding rehospitalizations and how that plays a toll on patients. And just additional resources that are available to you, including hospice, palliative care, home health, and Medicaid programs. So there's different types of living for the experienced. I don't like to use the term elderly, so I just say our more experienced residents. There's different levels of care. There's independent living, assisted, long-term care, skilled, acute rehab, and what is called CCRCs, which are continuing care retirement communities. So when you think about independent living, this is, literally can be in a home or an apartment living. These are for people that can still live independently, but enjoy having access to assistance when needed. They have convenient access to dining, medical care, it's a safe living environment, but there's minimal assistance. So a lot of times when you have people that are wanting to be empty nest and don't want to have to deal with the tolls of having their own home, independent living, what is considered a retirement community, that is the first level of care where someone may live. So there's services that are available to these, these communities, but not to such a high degree. So, you have, these two residents, Sally and Bill, they're together, they're living and then kind of enjoying life after the children have left the nest, and they're trying to live the better part of their years. But as time goes on, Bill may not be around anymore, and Sally's by herself, and she may need a little bit of assisted living, and that's really where people are having difficulty with doing the activities of daily living. I mean, they may need help with bathing, toileting, getting dressed, needing some help with meal preparation. So that's the next level. Now, that can still be in the same type of environment, but there's different scales and different scales of what is offered in terms of how much nursing care can be available. But when you're in an assisted living setting, people can still come and go as they please, but it's not as, it really isn't thought of as apartment living per se. It's now you are in a structured environment where family typically brings their loved one out. As the scale of care increases, also the need of the patient. So a lot of times they will have activities directors in these locations so that people can feel involved. They try to do activities in the location, they'll even do a field trip, taking an outing to go to Walmart so people can go grocery shopping and just feel like they're not in the confines of a structured environment where they're still living independently, but they're really in a different level of care. So next is long-term care. This is where you are in a long-term care facility. Typically, people can pay privately, but that's where Medicaid can actually take over and help finance this type of level of care. So these are patients that are completely unable to perform activities of daily living. These are the residents that need assistance with basically all needs, whether that be bathing, toileting, just even getting up and just moving, really. Those are our long-term care residents. Everything is provided to them, their transportation, their meals, that is about as extreme of care that you will need. So this is one of my locations. It's called Sandy Lake Rehab. They provide both skilled rehab and long-term care. What you will notice is if you were to go look at different communities, you will see that there's buildings that look like the Four Seasons and buildings that have been around since 1950. What I think is very important is that you do not get lost in the lights and fireworks show. So whenever I tell people, whenever you're exploring a community, do not get sold by the $10,000 chandelier that's in the front, because the reality is they have to pay for that somehow. And the question is, are they cutting corners in order to make that happen? So the reality of some of these communities is it's the people that make the buildings. It's not the brick and mortar that make those communities, okay? Sandy Lake is right down the street from here. I'm a pretty big advocate of that building. I've been there for about 8 years, and I think, pound for pound, it really is the epitome of what, a skilled rehab should be. I mean, they provide a good aggressive therapy for our skilled residents, but I have long-term care residents I've taken care of for the last 6-7 years now. So, then there's other locations and I bring these two locations up because these are the ones that are nearest to this facility that I'm connected with. But then we have another newer one called Las Brisas Rehabilitation and Wellness. And if you look at the community, it's a gorgeous community. It's still trying to build its name. It's a newer building. It's been around for a little over 2 years, and they're still, trying to get it filled just because it takes time to build a reputation and to put that name out there that they're providing good care. So what is the difference between acute inpatient rehab and skilled rehab? Well, acute inpatient rehab, you'll have different ones such as, Baylor Inpatient Rehab, Texas Health has their acute rehabs, Clear Sky, Encompass. You hear a bunch of these names. Well, the difference is, first of all, the standard length of stay of these places are about 16 days. You have to be able to endure a minimum of 3 hours of therapy. If you cannot do 3 hours of therapy, you will not be accepted into these rehab facilities. So typically, when a patient has been hospitalized, all it takes is about 4 days of being in a bedridden state before your muscles begin to atrophy. So all it takes is, if you're in the hospital for a week, your muscles already have atrophied and you're going to become severely debilitated after just being in the hospital for a week. So the rule of thumb is, for every day after that first 4 to 5 days or so, for every day that you're in the hospital, it takes a minimum of a week per day that you're in there. So if you're in the hospital for 2 weeks, you're going to require a minimum of 9 to 10 weeks of therapy. Now, that doesn't necessarily mean that you'll get all of it in a skilled setting or an acute rehab setting, but you're going to need a minimum of 10 weeks, and that includes acute rehab, skilled rehab, and what is called home health, where they have home health rehab or outpatient therapy. So in a skilled rehab setting, the length of stay is a lot longer. It's not required to be able to endure as much of therapy. They're supposed to be able to endure at least 1 to 2 hours of therapy. And the thing that I will explain to you is it's a very tricky slope of what the insurance will allow. Ironically, if a patient is not performing well in therapy, the insurance will be ready to pull out. If the patient is performing too well, the insurance is ready to pull out. So you almost have to show a gradual improvement, but not so significant that they want to pull out early. Because the reality is, the longer that you get therapy, the longer you're in a monitor setting, and the longer it is likely that you will not return to the hospital. So the reason why they have these acute rehabs and these skilled rehab facilities is very simple. If people discharge directly from the hospital back home, the likelihood of them returning to the hospital increases exponentially. So the insurance has gotten very smart about saying, okay, let's put them to the next level of care, where it doesn't cost them as much money, and really this is the next level where they can still be in a monitored setting. So all I do is post-acute care. All I do is take care of patients that were discharged from the hospital, and my job is to try to make sure that their medications are optimized, that they're doing well in therapy, and do everything that I can to try to keep them out of the hospital. Because there's a lot of evidence-based medicine that shows that every time you go back and forth from the nursing home to the hospital, the patient declines significantly. There's a lot of literature that even talks about the ambulance ride in itself causes a lot of stress to the geriatric patient. So we want to avoid all of that and try to be proactive, not reactive in the care of the patient. So now the difference between acute rehab, there's a daily physician visit. In the skilled rehab setting, you will be seen by a physician or a mid-level, whether it be a physician's assistant or a nurse practitioner, about 1 to 3 times a week. We go to Sandy Lake, for example. We go 3 times a week. My nurse practitioner goes twice. I go there once. And then there's other buildings where I go twice and she goes once. So we're 24/7 on call, but that's the difference between what is acute rehab versus skilled rehab. Now, there are situations in which a patient is not eligible for acute rehab because they can't endure 3 hours. But what we do is we take them under the skilled setting, get them strong enough so that they can be strong enough to go to the acute rehab setting. So we communicate and work with these other buildings to try to get the patient as much therapy as they can get. And the Medicare and Medicaid dollars that are used to pay for these things work under different systems. So if they used up their skill days does not necessarily mean that they used their acute rehab days. So there's a whole other slew that I won't go into, but the more you know about what's available to you, you can acquire these things and people can advocate for you, okay? So CCRC, a continuous care retirement community, those are places that literally have assisted living, long-term care, skilled nursing. It's just a big, big community, and it's keeping it all within the network so that there's this lateral transition of care. There's places that have individual homes, then there's apartment living, assisted living, memory care, and skilled rehab. And a lot of this post-acute care world is driving towards this so that there isn't this transfer of patients all over the place. For example, Sandy Lake has skilled rehab and it has long-term care. We do not do assisted living. We have assisted livings right next door. There isn't a long drive if there is that lateral transition. Las Brisas has assisted living, so they do skilled rehab, they do long-term care, and they have assisted living. So that if there is a need for the next level of care, you could do a lateral transition as opposed to going to a whole new community. And there's a lot of buildings that are choosing this model to avoid putting the stress under the families when making these decisions. So you get a whole all-in-one experience. Okay, so one of the things that I really like to talk about is advanced directives. So what are advanced directives? Well, it says it in the name. It's directives that are discussed in advance so that we know what you would like done with your care before the heat of the moment. The decisions about whether to be a full code or a do not resuscitate should never be done in the heat of the moment because that's where emotion takes place, right? So these are discussions that should take place amongst you and your family members so that you can arm your children with what your wishes are. Now, what is involved in resuscitation is it's a generalized term, so I'll kind of get into that. And also, just kind of giving you information about how do I get my advanced directives known to the doctors and the nurses wherever I may go. And don't automatically assume that your advanced directives are transferred. The mistake that a lot of people make is that when they're in a hospital, they'll say DNR, and then they're transferred to a skilled rehab, and then they assume that all the paperwork follows them. That's not necessarily the case. In fact, in a skilled rehab, we have what is called an out-of-hospital do not resuscitate form. That is basically a form that tells the paramedics that they still can go to the hospital, but if the patient dies in transit, to let them go peacefully. So one thing I always try to tell people is do not resuscitate does not mean do not treat. It just is telling us how aggressive should we be in the, if something catastrophic were to happen. And I'll get a little bit into that. I give very specific statistics. I'm a very, numbers-based guy, and I like objective numbers because it kind of gives you better insight. And then it's important to know, like, who do I have advocating for me if I'm not able to speak for myself? Who is my medical power of attorney? So one of those things that nobody really wants to talk about these things because it's kind of dark and it's not something that's really positive. But what I will tell you is you never want your children to make assumptions about what your wishes are in the heat of the moment, because the thing that I make very clear to all my patients and their sons and daughters is we only get one parent. We only get one mom, we get one father, and nobody wants to lose them. But by the same token, if there's one absolute that I've learned as being a physician, I've learned a couple of things. Number one, that there is a God. And number two, I'm not him. I've also learned if there's one absolute truth is that every single one of us in this room is going to pass at some point in time. Okay? We do not have control over the when. That is not under our will. That's planned. The higher up, he makes that call, right? But we do have somewhat of a say of how we go. And I always explain to people, how do you want to go? Do you want to go, kicking and screaming to the last breath of life, or would you prefer to be sent off in a limo? And me, I would prefer to be sent off in a limo. And there's a way of doing that with giving people dignity and respect, right? I wanted to show you this slide because it's a very specific slide that I use, and I draw this out for my families every time I have them come in. So when you're dealing with anybody over the age of 75, and you have people with congestive heart failure, COPD, history of stroke, dementia, there is a gradual decline every time they go to the hospital or every time that they have a fall. So if you look at the top graph, that is intended for chronic conditions like COPD. Every time they have an exacerbation or heart failure exacerbation, they really dip down, and then they improve and they plateau. But if you notice that when they recover, it's never quite at the baseline before they were hospitalized. And then they carry along for a little bit, then they take another hospitalization, they improve, and then they plateau. Now, when you look at the next graph, that's the typical progressive decline of dementia. It's a slow, transient decline, but it's still a decline nonetheless. And then the last one is when people find out that they have a situation like cancer. They find out, the realization kicks in, and then they kind of lose all will a lot of times, and there's an acute decline, and it's pretty impressive how much our body, takes over when people just kind of lose that will, if that makes any sense. So, unfortunately, this is not like pediatric medicine. It's not like the saying, whatever doesn't kill you makes you stronger. And when you're dealing with geriatric care, it's important to arm my patients and my population with knowledge that, when we take an insult to our body, we don't really get back to that baseline. So it's important to understand this concept because, the more the more you can arm yourself with, telling your family, okay, this is what I want for my care in the future. So there's different levels of resuscitation. So what does that mean exactly? CPR, that's when you're doing the compressions, and what I will tell you is there's never been a situation where I've done compressions on a patient where I did not fracture the sternum. And to be perfectly honest with you, if someone's sternum has not been, fractured, I don't think they're really doing it right, because you have to mimic the same type of force as the heart would in order to get the blood pumping. Now, there's different levels of resuscitation where people will say, well, I don't want compressions, but I want medications. And I will tell you, there's been this gray area of how much we can do in resuscitation that I feel like that sometimes facilities will allow people to pick and choose. And my kind of answer to that is it's not like Burger King. You can't have it your way. You know, typically when the heart goes, the lungs go. When the lungs go, the heart goes. And I'm like, we either are going fully aggressively all the way, or we're not doing anything at all, because to kind of give people the false pretense that we can fix things by doing the bare minimum, I think is a little bit misleading. Does that make sense? So so when I'm talking about resuscitation, the main type of resuscitation I'm referring to is what is called chest compressions and intubation, okay? There's other types of resuscitation, whether it be giving vasopressors. Vasopressors is a medication that you get in the ICU to raise the blood pressure. There's mechanical ventilation. There's non-invasive mechanical ventilation. That's like your BiPAP. There's artificial nutrition like TPN, that's nutrition that's given via the veins, tube feedings, IV feedings, and hemodialysis. So there's different types of resuscitation. So when you say, I don't want to be intubated, I don't want to be chest compressions, that's a DNR, DNI. That does not mean that you cannot get dialysis anymore, okay? So there's different levels. That does not mean that you cannot get antibiotics or IV fluids. So it's important to make it clear, like, hey, as long as it's not overly invasive, if that's what your wishes are, those are discussions that you have every right to have those with your physician, and nobody should give you the sense that they're too busy to have that conversation with you, okay? Nobody has a right to tell you what you can and cannot do with your own body, right? So, so let me just kind of tell you, why do I feel very strongly about the whole statistics in CPR? I read a lot of different studies. There's a lot of literature out there, and what the take-home message that I've learned is what the general public, their impression of resuscitation is what they've seen on television. And on television, it makes it seem that we bring back about 40 to 60% of patients, and that is the furthest thing from the truth, okay? The reality is, depending on which study you read, it's like someone will say it's about 11 to 16%, others will say about 16 to 19%, and there's even other studies that will say, you know, if you have a history of coronary disease, you're in your 50s and you have a heart attack, there's about a 49% chance, roughly, that they'll be able to bring you back. However, that same patient has about a 10% likelihood that they will discharge home. So I kind of use 16 as my number, okay? So if you have 100 patients and 16 are resuscitated, that 16, that really, if you look at a pie chart, that majority are young and healthy people. It wasn't really intended to refer to people that are 75 plus years of age with chronic comorbidities. There isn't a lot of literature to support the resuscitation on an elderly person, but like I said before, I like numbers because numbers tell me something. So there was another study that I read where they talked about if you have a patient that's 80 years of age and they are perfectly healthy, they're pretty strong 80-year-old, and they have a heart attack, the chance of resuscitation at that point is 3%. If it's a person that has, that's 80 years old with like cancer, then at that point it's about 1.7%. So people will tell me, well, Dr. Hernandez, even if it's 1%, why wouldn't you try? And my response always is, it's not about whether I'm willing to try. The question is, would your mom or dad want to pursue these aggressive measures knowing that the statistics are against them when the process about it is very aggressive, and for lack of better words, it's a horrible way to go. It's not like organized like you see on television. In fact, when we code patients, it's very aggressive, it's very scary. You have this picture of like you're in bed and you have 4 people around you that are kind of in that panic mode, and I'm like, is that comfort and quality of life? Now, I will tell you, if my 9-year-old son has something happen, my answer is yes, resuscitate him. But if we're talking about my 75-year-old father that's got chronic comorbidities, and the concern is not so much about can I get the heart going, what is the aftermath that comes along with it? Whenever somebody's heart stops, you worry about, did they suffer an anoxic brain injury? And yes, we can bring the heart back, we can get the lungs going, but then we put the burden of wondering, will they do okay after being resuscitated fully? Then it puts the other question of, what if we cannot get people off mechanical ventilation? Now it puts the burden on the children of making the decision of withdrawing care. And if you think that it's hard to make the decision of whether to be DNR or DNI, and now they're making a decision of withdrawing care, now the family member feels like they are killing their family member. Does that make sense? And it's an unnecessary burden that's placed on the children when some of these conversations could have been made in the first place. And I arm you with that knowledge so that you can start engaging in these conversations if you haven't done so already. Okay? You know, there was another study that I read many years ago, and it was a study that I read that basically asked physicians and nurses, and they got a good population, a really big population, and it was a one-question survey, and the survey was, regardless of your medical conditions, after the age of 75, how many would want to be resuscitated? And of the medical community, it was something like 96% said do nothing. They asked the same question to the general public, and it was your lawyers, your bakers, your accountants, and the general public said 80% said do everything. So the whole purpose of that study was to go back to clinicians and to say, what is it that we're doing wrong? What is it that we're failing in educating the general public that there's such a huge discrepancy in that one question? So when I read that study, I took it very personally, and that's why I feel in trying to educate people as much as I can, right? So another thing that I think that's really important for you all is reducing polypharmacy, and that's where I feel like people are taking too many medications. In my personal belief, nobody over the age of 75 should be taking 15 plus medications. I just don't agree with it. I feel like there should be more food in the belly, less pills. So I'm a big advocate of increasing the doses, reducing the number of pills, and reducing the frequency. I am a physician. I take medications, and I forget to take my blood pressure medications. So how do I expect my patient to take something that's 3 times a day? So, you know, I'm all about trying to simplify it as much as we can. So, you know, kind of staying away from getting too many, when I have patients that are really big on supplements, they'll take, you know, their wheatgrass and their vitamin C, but then they forget to take their Coumadin or their anticoagulant because they're tired of taking so many pills. I'm like, okay, well, let's optimize this so that this is not such a burden. But you know, I think it's really important that people understand what they're taking and what for. It really baffles me when a patient has had a congestive heart failure that's been seeing the cardiologist for 15, 20 plus years, and they don't understand what their beta blocker is for. And I think that's in part, you know, failure of the system and just the presumption that people just won't understand. I will tell you what I've learned is people are smart if you just give them the time to educate them. You know, I didn't know this stuff when I was before I went into medicine. So if I learned it, why can't somebody else? It just requires taking the time to educate. So, you know, and what's important is knowing the difference between the geriatric medications and the trade names. So I'll give you an example. This is a common issue that I've seen throughout my career. How many know what Lasix is? The water pill? Y'all are familiar with that? Does anyone know what the generic of that medication is? It's furosemide, okay? The reason why this is important is because when a patient is hospitalized and they're on Lasix, the hospital's formulary will give them the equivalent furosemide, okay? Because that's what their insurance will cover. It's the same medication, it's just the generic. The problem is when the patient discharges, they're on furosemide, the patient goes home, and then the patient remembers, oh, my cardiologist said I have to take the Lasix, they forgot to put it on. So now they're taking furosemide and Lasix together. And now they come back within a week, now they're in acute renal failure because they've doubled up on their medication, okay? The other importance is just because you've been in a hospitalized setting does not mean that everything is safe. I've had patients where they've gone on a medication called Combivent, which is for COPD, and they come back from the hospital on Combivir, which is for HIV. And now this patient has got an HIV diagnosis. So the more you arm yourself with knowledge about what am I taking and what is it for, it really reduces these problems that can occur. And then, of course, the problem is, I always tell people, do your best to not fabricate your compliance with your doctor. I think people think that the doctor is going to lecture them and, they don't take their blood pressure medications. And then, of course, like the day before, they take the medications when they have their follow-up appointment. It doesn't work that way. And the problem with that is when people are not completely honest about how they've been taking their medications, for example, diabetes. Controlling your diabetes is not an easy thing to do. The problem is when people are not compliant and then they come in and their A1C is really high, the doctor assumes, okay, the regimen I have them on is not working. I need to increase the dose. And sometimes people have these come to Jesus moments where they're like, oh, I need to start taking care of myself. They then take the increased regimen and then they've bottomed out. So it's always important. I try very hard not to write stuff like non-compliance. I will say non-adherent because we don't want to give buzzwords that it tells the insurance that you're not doing what you need. I'll say non-adherent because of cost of medication, right? So I always educate my staff not to use words like compliance. I think it's got a very derogatory type of jolt to it. And then it's important to know about what medications can interact. There's some really important ones, like if you're taking Coumadin, if you're on an antibiotic, it's important to tell whoever's prescribing that medication, like, oh, by the way, does this affect my Coumadin, and so on and so forth, okay? So I always encourage people to talk to their primary physician about what medications that can be reduced, and the reason why is this. A lot of times when people are in the hospital, they'll be on their general medications, let's say they're 10 medications, and then they're added on 6+ as-needed medications. And then what ends up happening is there's these 6 meds that they weren't on before that were just as needed, and then when they go to their primary care physician, because another doctor wrote for it, it's now added into their MAR. So now the patient is now officially on 16 medications, and that's how this stuff piles on, okay? I ask people, like, how long do I need to take this medication? When can I wean myself off? When I hear people asking me something like that, I love it. Because, like, okay, this is someone that's being proactive about their care. So when I feel that they are, more engaged in their own care, I feel that I can trust, okay, if you're feeling better, you can wean yourself off this medication. Rather than just relying on the next person to take the baton and assume that they're going to reduce it for me, okay? I also tell people, if you're not in pain, don't keep on taking the pain medications. Well, we are a huge part of the problem of substance abuse in the United States today. And I'm having when I'm seeing a lot of 80 and 90-year-old patients requiring pain specialists, that's a big problem because people stop using the pain medications for pain and they use it to try to no longer deal with reality. And that's a whole other issue. And then when they actually need the medication, they're on such a high dose at baseline that now when they fall and they have a hip fracture, they're going to need something completely concerning that could cause them to be overly sedated when they actually need it for pain. So the other thing I always tell people is try to avoid asking for antibiotics. If you have a scratch and don't ask a doctor, can I get an antibiotic for that? And in today's culture of wanting to please our patients and of being afraid of, the reviews that we may receive for not listening to the patient and, not giving them what they wanted, there's been this big outflux of medications that are just not necessary, and that's why there's so much antibiotic resistance. So you have to be careful. Antibiotics are not a benign thing. So there's a condition called Clostridium difficile. Antibiotics kill bad bugs, but they can also kill good bugs that are in our intestine that block out other bad bugs. So when we take something for a UTI or upper respiratory infection, it wipes out our general beneficial flora, and then we end up with C. diff, and then we're now having to take a bunch of antibiotics to counter that, and it can cause severe amounts of diarrhea, dehydration, and it's very difficult to treat. So, and then, sleeping agents. People always say, can I get something to help me sleep? Well, it's more about learning more about better sleep hygiene. Does a patient need a CPAP instead? Are they micro napping all throughout the day and then they say, I can't sleep at night? Well, we need to kind of change that whole circadian rhythm. pills don't fix every problem. Does that make sense? Pearls for preventive care, it's always ideal to have a great quarterback. And I mean that in both your primary care physician and also your loved ones. Having someone that knows what you're taking and someone, your sons or daughters, niece, nephew, whoever it may be that can help you with knowing what medications, should you be in the position where you cannot speak for yourself. People that can advocate for you when it's going to these different appointments. I'm a physician, but yet I still need my wife to accompany me at times when there's too much information because I don't want to miss anything. So it's the same thing when you're going to the doctor. It's always good, not a bad idea to have somebody with you so that all the information can be gathered. Sometimes it takes two people. If you talk to me in terms of anything that regards the law, I'm going to need somebody with me, right? Also knowing about who your subspecialists are, knowing who your cardiologist is, nephrologist, pulmonologist. So what I always tell people is it's when people say, well, I want the best doctor at this hospital system, and I've got this best doctor at this hospital system, and this doctor is at this hospital system, and I will tell you that's not a great idea. What's important is that you stay in one system. And the reason being is because they all communicate with each other. People will assume that my cardiologist at Baylor, that he's communicating with the pulmonologist over at Texas Health. And that doesn't always work out. You want to work in the same system. If they're in a pulmonologist or a cardiologist, they're probably pretty smart people, and you want to stay in a network where people are communicating with each other. So it's really good to stay in one system if possible. So avoiding rehospitalizations, it's important to be compliant with medications, obviously. Knowing your medical conditions, for example, your COPD, heart failure, Crohn's disease, what are things that will cause flare-ups and how can I avoid those situations? And, if you're in a skilled rehab facility, there's many times where people are chomping at the bit to be discharged as soon as possible. And I tell people, do not give ammunition to the insurance of saying, hey, the family forced a discharge, and if you don't do well and you need to come back, you don't want to give a reason for them to say, well, we try to get you better and you did not choose that option. So the important thing is sometimes the longer you stay or the shorter you get yourself out of a skilled rehab, you may end up prolonging your rehab when you get rehospitalized, and it would have taken if you had just waited another 5 days to get yourself stronger. It happens all the time. People say, I don't want to be here anymore. I want to go home early, and they fall, they break a hip, they're rehospitalized, and now they've been out of their home for now 2 months. When if only they had stayed 5 more days, they would have gotten strong enough, and that could have been avoided. So I wanted to talk, I have a couple of people that are here that can talk to you about home health, hospice, and I have some people from Medicaid Solutions, so I have Wesley with home health. This is Wesley Cherian with V-Care. You have a mic? Oh, right here? There we go.
Can y'all hear me? So just like the name suggests, home health is basically services at home, services within the four walls of what you call home. It could be a home or it could be in a facility setting, but it's what you decide to call home. And that's where we come in. And just to kind of echo a little bit of what Dr. Hernandez was saying, the whole purpose why we're put in place is to prevent rehospitalizations. We don't want you to go back to the whole circle of hospitalization, skilled nursing facility, whatever it takes you to get you improved into a better setting. That's what we're trying to avoid with home health. And so we work in partnership with your physicians. So this service is ordered by a physician. So it can be a physician in any setting. It can be your own primary care doctor, or it can be a physician in your rehab setting. And the whole purpose is, we kind of follow the progress you already made in that skill setting. Or if it's in the hospital, we follow the progress you made in that hospital setting. What we are trying to do is not take a step back. So as long as we're making a step forward, it's always securing you for your independence at home. And just because we get involved doesn't mean we're there forever. We're there only for a very short period of time. So our goal is to make sure you guys make that improvement, and as long as you make that improvement, we can leave. And the whole thing, like I said, as long as you guys feel comfortable, we can be there as long as you feel comfortable. So let's say the initial plan is to stay for, the initial plan is always six weeks. So let's say that 6 weeks didn't pan out as planned, you need a little longer, then we can always take it back to your doctor and see what their recommendations are, and then kind of work up a new plan for the next 6 weeks. But our goal is, as long as we make progress, we can always stay involved. And primarily, the whole service itself is covered by insurance, so there's not out-of-pocket cost to you guys. So this is something we work with insurance. So what your payer source may be is what we'll cover for the service, and we provide services as long as they are also open to that idea. So as long as you guys make progress, we're able to document it and prove it to them that we're making progress, and that will enable us to stay there. So that kind of summarizes what home health services is.
So typically when a patient is discharged from a nursing home, the same way the hospital wants to go to the next level of care, when they discharge from a skilled rehab, we will set them up with home health so that there's still services that are provided, including physical therapy, occupational therapy, speech, and maybe a skilled nurse. So a lot of times, if a patient has like a wound and we really have recovered that wound, we will pass that baton on, and instead of it being 5 days a week of therapy, it's going down to 3 days a week, but now it's in the comfort of your own home. So what it's proven is it once again reduces that likelihood of that patient returning to the hospital. There's been many situations when a patient is with home health, and if the patient is declining and it's been within a window where they were discharged from the skilled rehab, the home health communicates with us, and sometimes a patient is readmitted to the skilled rehab to avoid that rehospitalization.
Do you guys have any questions?
Thanks. Thank you, Wesley. And I'll give an opportunity for you guys to ask questions about the different modalities. One of the other areas of care that we provide or that we network with and people that work with us is with hospice and palliative care. There's different criteria that meets for what makes a patient a candidate for hospice, and to kind of basically give the summarization. It's whenever it's predicted that a patient is going to decline or pass within 6 months or less, they are a candidate for hospice, right? Now, a lot of times people make the misconception that hospice means my mother or father is going to die in the next 3 days. That, I think, has become the standard mindset, but in reality, a patient is considered eligible for hospice if it's projected that they're going to pass within 6 months or less. Now, if a patient survives past 6 months, but there's still a continued decline, they would still meet criteria. Why has this happened? Well, number one, there's a lot of information that has taught us that the number of healthcare dollars that goes into that last month of life when people are going in and out of the hospital surpasses the majority of the lifetime, meaning every broken bone, every clinic visit. So when you have an elderly patient that keeps on going in and out of the hospital, going into the ICU, it's a considerable amount of monies, but also is it really providing benefit to the patient? So they have allowed for hospice to be approved for a longer period of time because they're trying to reduce the amount of frequency of visits. Now, typically a patient will be hospitalized once every 2 years. Then it becomes once every year. Then it's like once every 8 months, once every 6 months. But there's a lot of evidence-based medicine that shows that when a patient is getting rehospitalized like every 3 months or so, it's a telltale sign that we're becoming very limited on time. So there's resources, and I have Stormy Clark with VNA Hospice. I don't know if you want to mention anything. You could, yeah, if you just want to just put you on the spot.
Hi, I'm Stormy. Oh, I yell. I'm sorry, I project just naturally. Sorry about you.
So do I.
I'm Stormy Clark with VNA, the Visiting Nurse Association of Texas. We do hospice care. And let me tell you, the biggest misnomer, just like Dr. Hernandez said, is that we essentially are morphine and off to the Lord. It is very much a level of medical care, and it is something that we come across. When you are wanting to start considering hospice, when you are wanting to start looking down that path, the things you need to ask yourself is if you are aggressively treating the disease in which you're dealing with. So, for an individual who is no longer seeking or is no longer eligible for cancer treatments, for someone who's been dealing with congestive heart failure for a very, very long period of time, and there aren't any more procedural steps to take regarding curative measures, that might be when you want to give a hospice company a call and see if there might be something they can do. It is intended to be supportive in every step of the way. Side note, Medicare, managed private insurances all do cover this as well at 100%. But it is intended to be supportive, not just with clinical. You have physician in-home, you have nurse in-home, you have certified nurses aid in-home as well. You also have the benefit of social work and chaplaincy. So it is intended to be spiritual, emotional, and physical in its support, okay? I'll be brief. I know we do.
And last, you know, in order to become eligible for like long-term care, there is lawyers that specifically focus on, you know, getting people eligible for Medicaid. One of the big problems that people always worry about, well, mom has these assets, she's not even a candidate for Medicaid, and there are lawyers that are specifically, you know, licensed to help families, you know, make these types of decisions and what is the easiest channel. And for example, our community over at Sandy Lake Rehab, we have what is called Medicaid pending beds. These are patients that we can actually give them a home while we're working on that process of becoming eligible for Medicaid. And when they get approved, then there's they look back and the insurance will pay for the time that they were there. But I've got some people here from Medicaid Solutions. This is Jonathan Rosamund and Fatima Wiggins.
Hi, thank you. So my name is Jonathan Rosamund. I'm an attorney, and when our clients retain my firm, what I do is work with folks at Medicaid Solutions for Texans, and we work specifically on Medicaid applications. Fatima, along with the other staff there, have tremendous amount of experience with this. Fatima was a former business office manager of a nursing facility. Our other staff are former Medicaid caseworkers. I'm going to let Fatima, she's done many more of these pitches than I have, go through her spill, but before I do, I want to take a quick step back to the AMDs and the medical powers of attorney, because that's a big part of our practice as well, is providing that service. And it's something that I don't just tell this room, I tell my friends, I tell everybody, you have to have medical powers of attorney. You don't know when an accident's going to happen. You don't know when you're going to need it. And you do need to have your wishes honored. I can tell you in my own life that my mother, if I let her make the decisions, would make decisions different than what I want her to do, right? I don't want her making those decisions. Fortunately, my wife knows what I want, and she's my medical power of attorney, so she'll make the right decisions for me. But those are documents you need to have in place because you don't want that to be guesswork. That's something that we can provide, but if you don't come see us, go see an attorney or get online, figure it out. You need to have those documents in place, because when we have clients come in to see us, in addition to medical power of attorney, a financial power of attorney makes a big difference, especially if we have clients where maybe we've had a massive stroke or dementia has set on aggressively. If we don't have a power of attorney in place to work with the spouse, it really makes it difficult, or with the child, it really makes it difficult for us to do our case. And if you end up in a case where you have guardianship, then you have an attorney you maybe didn't pick who's got to look over the shoulder every decision that's made. You've got to go to court every decision that's made just to move forward with something as simple as a Medicaid application. With that aside, I'm going to let Fatima do her thing.
Thank you. Well, pretty much I like to kind of just explain that Medicaid is a very, that people get information. So I pretty much like to say that, we like to take the mystery out of Medicaid. We like to make it as simple as possible and explain it to our families and clients, how Medicaid works if you're going to take the route to be in the nursing home Medicaid. A lot of people think they're going to have to spend all their money down, and it's always under $2,000, and it's not true. This is what we're here for. This is, where, our clients come and get information, and we pretty much educate too as well. Because like I said, they get misinformed, they get, wrong information. So, we try to preserve as much money as possible as well. All the hard money that they worked or they invested, we try to, like I said, preserve as much money as possible as well, also protect, their home. A lot of people they don't know that we're able to protect their house. They think they have to sell the house and spend all of the money, and it's not true. But I don't want to take too much time because I know we're in crunch time. But we're here to help. I have some information if you guys would like to have our information just to take a look, and we're here to help. Any questions or anything, we're here.
Just to add very quickly, I think the biggest misconception Fatima is saying is that when it comes to Medicaid, most people think about Medicaid as being a poverty program. It was set up as a poverty program. That's how it was set up. But it was set up a very long time ago. Unfortunately, we haven't had the political willpower to reform it. So what we have now are a system of complex rules with a lot of exemptions and exclusions that allow the overwhelming majority of people, if they have their estate planning done correctly, to qualify for Medicaid. And we have a lot of clients that walk into our office thinking it'll be months or years before they could qualify, and we tell them they can qualify today. We just have to put the right planning in place. And as Fatima pointed out, we're all about preserving the wealth and the legacy for folks to be able to pass that to their families, as opposed to just passing it over to a nursing care facility, because at the end of the day, you're going to end up with the same care. It's just a question of who's paying for it.
Thank you. And I really would encourage you to try to get any of the literature from each one of these people. They came out of their way to provide you guys with as much knowledge power as possible. And the reality is, you're going to need any one of these people at some point in time. I've done these talks before, and I will get phone calls from people that I gave a talk to a year ago, and they'll say, "Hey, Mom just had a hip fracture, and what's the next step?" And I want to get people connected to the right people, and it does not matter if it's with me. What's important is that I've done my job in trying to educate people as much as possible. And if I get you connected with the right people in terms of home health, with Medicaid solutions, with hospice, I've done my job. Does it make sense? But just kind of piggybacking with also about the misconception of certain things. I'm not going to hash on one subject, but it's important to understand, when talking about code status and whatnot, the same question can be asked, but it really depends on how it's asked. So when I talk to my families, I will ask them a question like, if something catastrophic were to happen, and their heart were to die, I'm very specific. Would they want extenuating measures to be resuscitated? In the ER, a lot of times I hear families say, well, they just said, hey, if anything goes wrong, do you want us to try everything? Who in the right mind will say no to that? So I'm very specific about, I tell people, I'm going to do everything I can to take care of them. However, if something extreme happens and we were to walk in and they're not breathing, what do you want us to do? So it really depends on, the perspective of how things are said and the misconception of what people kind of expect. So is there any questions for any one of us? Please.
I have a question on the do not resuscitate order.
Yes.
If you are out of state.
Let me get you a microphone.
Hi.
Blue.
If you are out of state
and I'll use my dad as an example. He was in Florida. I lived here. He fell over. Emergency picked him up. They took him to the hospital. I finally got notification that he was at the hospital for an hour and a half. And they said, we're trying to resuscitate him. I said, he has a resuscitation order. She said, well, stop. But he was living alone. Now, how do you notify them that you have a resuscitation, non-resuscitation?
That's an excellent question. And you're a perfect example. You just gave a perfect example of the assumption that people have in those serious decisions, right? The reality is it depends on if his primary care physician is in network or where he went to the hospital. You know, that stuff should be on the medical records. When a patient is discharged from the hospital and they go to an acute rehab or a skilled rehab, they're not of the same entity. So it's important to know that when you want your wishes, when you make any kind of movement, it's important. Now, I will tell you, did the paramedics do anything? They don't know. The answer is you would rather do something and be wrong than not do something and be wrong, right? With that being said, I'm very sorry that your father, had to go that way. With that being said, it's not a perfect science, and it's, if anything, all the more reason why you're a perfect example of the importance of making sure that there's a contact list, that it's an easy access of who's my medical power of attorney. I tell people, like, when you have your billfold, have contacts, like my medical power of attorney is in there. There's people that literally have been tattooing on their chest, do not resuscitate, because when they open up the shirt, it's on there. There's nothing more than that, and I kind of support that. You know, I mean, they will tattoo it on there because they don't want to pursue that anymore. Yeah, please. Oh, yes.
Something in the state of Texas, every state has their own
You know what, for the feed, we'll want you to have this.
I'm sure they can hear me down at the Tom Thumb. In the state of Texas, every state has their own independent. It's a government drawn up form called an out of hospital do not resuscitate. With our hospice patients that we serve, what we tell them to do, the places that EMTs will automatically look, is the back of a front door and the side of a fridge. We encourage our families to make multiple copies of them. I also see a copious quantity of folks take them, put them in a Ziploc, roll them up, put them in a big pill bottle, and put them in the freezer. This is a whole thing. See, you know what I'm talking about. I see it all the time. But EMTs will always check the back of the door and the side of the fridge for a form like that.
Thank you. That's important for me to know. Any other, please, that's how we learn, is through questions. There's no silly question. That's what we're here for. Anybody else? Okay, well, we're going to do a pop quiz. Okay, anything on home health, hospice, Medicaid, anything like that? Okay. Well, I hope, please.
How do you get your kids to talk to you about this?
Well, that's a great question. Please. The question was, how do you get your kids to talk to you about this? I think that's initiated by you all, and it's not, pleasantries. I'm sure they would much rather discuss, hey, I've got some money and I want to take you out to the Bahamas. But the thing is, it's like, you need to set time aside to say, hey, I really would like to sit down with you and talk about my wishes, and so we can work. Can we talk about this? I think it's very important that you understand what my wishes are and what I want. I'll tell you what happens. A lot of times the offspring will talk about, well, I know mom wanted everything done, and they'll say, mom always said she wanted everything done. Yes, mom said that when she was 67. She's now 83, and the game is completely changed. So, and the reality is, as you talk to patients, as their bodies take toll, and if they're chronically in pain, people don't want a lot of things aggressively done to them. What I will also tell you is, what I've learned in life is, as I talk to people that walk the right path, I'm a member of Messiah Lutheran in Keller. What I have learned is when people walk the right path, they're not afraid of death. I think they're more afraid of the burden on their offspring. They're more, I think there's a lot of guilt where people think that they don't want to tell their loved ones, I don't want to keep on pushing. And you know what? It's okay to say that. I've had many families tell me one thing, but in the presence of their son and daughter, they tell a completely different story. And that's where I have to do my job to advocate for them. So I think nothing would arm you better than to talk to your son and daughter, say, look, I want to talk about what my wishes are and how aggressive I want. And of course, it may incite a little bit of fear. Where it's like, Dad, is there something you're not telling me? Well, what did the doctor tell you? What's going on? And you just say, you know what? We don't know when our time is going to come. So that's why I think it's important. It's just another reason to congregate and speak to your family, right? It doesn't have to be a negative discussion. So, anything else?
I guess I do have a question for the attorney.
Oh, please. Good.
And I don't know if this is typical of Florida, because I know exactly what Florida does.
In order for my dad not to go through probate and everything, my name was on everything, on his checking account, on the house, on everything, except we screwed up on one thing. It was on everything except the land. And we had to go through probate because we messed up on that one little thing. So, you know, my thing is I'm going to have my kids listed on everything, as long as they don't hit my savings accounts.
Yeah, you bring up the bigger issue of probate, and for folks who don't know, is when someone passes away, in order to pass the property, you go through a court proceeding. And it's kind of the way we've always done things, but it's not really necessary anymore if you set up your estates and plan it properly. With respect to the house, there's several different options. If you're doing basic estate planning, you can pass it through a trust, right? So we create a trust, we put the deed of the house into trust, you stay the trustee, the house will pass when you pass. With Medicaid estate planning, in order to preserve the house, we actually use a special form of deed called a ladybird deed, what is called colloquially, but it's the legal term is called an enhanced life estate. And it's where you transfer the property now while you're alive, but you retain the benefit to sever that transfer at any time. So you can qualify for Medicaid because you still have a homestead. You didn't make a transfer without value because it's not a transfer until you pass away. But the moment you pass away, it passes without probate. Probate in Texas is not as bad as it is in a lot of states. It can be handled pretty inexpensively and pretty efficiently. The problem with probate, which is the point you're making, I think, is one, it can be long, and two, it puts the world on notice that somebody passed away, they had assets, and the assets are going to these other people. And it really sets people up for scammers. It sets people up for creditors, and lots of folks come calling. It's something we help with, but whether you, again, see us or see somebody else, we do encourage people to do that type of estate planning. With property, you have multiple avenues to pass it where it doesn't have to go through probate. Another thing I want to encourage everyone, if you're married, to get what's called a community property right of survivorship agreement. Most married folks think, if I pass away, my spouse automatically gets the house. That is not how it works. The spouse will get the house, but you can do it with probate or without probate. And one little piece of paper will bypass probate. So if you have questions, you can come ask me directly. Probably already answered a little bit more than that question asked.
Is there anything else? Well, I'd like to thank you all for coming, and I hope this was informative, and it will help you just kind of guide at least minimum discussions with your family members, arming you with knowledge of like talking to your physicians about optimizing your medications, talking about code status, and at least giving you some resources where you guys can, take that next plan. There's some literature, for Medicaid solutions that they're going to pass around. Do you have any, Wes, with you with VCare? Okay, if you don't mind. And that way you guys can, and then VNA Hospice has some literature for you. If you guys need anything in the future in terms of what is the next step, Marilyn, if you don't mind us being a connection, I respectfully don't give out my phone number to everybody because people just start calling me out of random, well, hey, my granddaughter just had a fever and what do we do? But Marilyn can be the contact, and I'd be more than happy to talk to you and see where we can help in the future.
Okay. And I think we ought to all say thank you.
You're very, very welcome. Thank you so much.
I believe there's literature in the back, or these people will be back there, so we'll go ahead and say goodnight.